Well, hello, everybody. Can you hear me okay? It's my pleasure to be here. I'm Eric Hart. I'm a clinical neuropsychologist for the University of Missouri. So I'm a psychologist by trade, and I'm board certified in clinical neuropsychology, and I am the director of adult neuropsychology for the university. I'm going to talk today about kind of an ambitious set of learning objectives here. In the interest of time, what I'm going to do is focus on just some of the high points. I want to talk about cognitive change. I want to talk about our current understanding of diagnoses, kind of distinguish between what cognitive change means in comparison to dementia, mild cognitive disorder. These are some terms, that I'm sure some of you are familiar with. I also want to kind of demystify the process of neuropsych testing. Some of you may be familiar as to what this is. Some may have a lot of questions about what all this is entailed. And so what I'm going to do is spend a little bit of time this morning going through this, a little bit of a frog in my throat. So without further ado, I'll advance the play. Okay, so what is clinical neuropsychology? So this is a subspecialty of psychology that looks at the assessment of brain and behavior functioning. We're using standardized measures to evaluate cognitive functioning. And by standardized measures, I'm referring to tests that are administered the same way each time to each patient. And we're using norms. And what that is essentially looking at how an individual performs relative to others of the same age. And these are largely paper and pencil-based tests. As a neuropsychologist, my role is to interview an individual who comes into my clinic. I'll go through their background history and to get an understanding from the patient, their family, caregivers, understand the medical reason for referral. So I'll look through notes, I'll look through neuroimaging. I will communicate with my technician, who will be the one who will be administering the paper and pencil testing with the patient who comes to the clinic. And then my role on the back end is to look at the information that was gathered and try to paint the picture of essentially what is going on with the individual to provide some insight to the patient, the caregiver, family members, and the referring doctor. And so our objective is to understand the cognitive change that is going on within the individual, to see if this is beyond expectation for aging, if this is beyond expectation for the medical condition that presents, and what implication this has with treatment planning, day-to-day functioning, and other recommendations that can help optimize someone's daily life. And so there are fairly lengthy evaluations, which I'm going to discuss in just a little bit. Just as an aside, I want to talk a little bit about kind of where our field has been and kind of where we are now. Neuropsychology has its origins about 50 to 60 years ago that sort of predates, this is a science that predates higher resolution neuroimaging. And so many decades ago, the objective of neuropsychology was to understand whether someone had an injury to their brain or dysfunction of their brain. And the objective was to understand whether the left side was dysfunctional, the right side was dysfunctional, and that was about the extent of what we had to offer as a field. Now, in the advent of more higher resolution neuroimaging, as I referenced, and especially now in the advent of new biomarker testing, our roles have shifted considerably. Our objective within the context of a neuropsychological assessment is to understand, as I mentioned, the cognitive profile, the extent to which someone is experiencing changes in their thinking, to conclude whether we think that these findings on our testing profile are consistent with what we would expect with somebody, say, for example, with Parkinson's disease at a particular stage, or if what we're seeing is the emergence of another condition that requires the clinician's attention. And so there's been quite a shift in our field and our focus and the application of our test finding. So this is, first important to point out, this is a non-invasive procedure. There's no needles, there's no poking, there's no prodding, there's a lot of talking. There's much of a dialogue, especially early on, finding out, as I mentioned earlier, from patients, families, caregivers, important people in their life, what has been most noticeable day to day from a thinking perspective. Certainly, we want to take into consideration the physical or the motor changes that go along with Parkinson's disease, but our role is to find out to what extent those changes that are going on in one's brain that cause the changes in movement actually are contributing to thinking changes. And what are some examples day to day that are most problematic? So we look at normal aging versus acquired change or decline. It's not uncommon for people to come in and say, my memory is different than it once was, but I think this is probably due to aging. And that can very much be the case. As we get older, whether we like it or not, our thinking sometimes gets a little bit slower, we can become a little forgetful, and that can be perfectly acceptable and perfectly within normal limits. We don't expect somebody who's in their 50s, 60s, 70s to have the same type of memory capacity in comparison to somebody who's in their 20s. So the very first question that we want to answer is, are these changes that you're experiencing, are those due to normal aging? And that is essentially the essence of the statistical analysis that we do with the test data that we collect. So the very first thing that we do is we look at test responses and we compare how the individual is doing compared to someone of the same age and background. Sometimes education plays a role in how well someone is functioning from a thinking perspective. We play a very important role in differential diagnoses. This idea of functional versus organic is a little bit of an outdated term. But essentially what that has meant historically is, do these cognitive changes that someone is presenting with, are those due to essentially a brain disease? Or is there something else in which the brain is the victim? In other words, is there depression that is going on? Are there sleep-related difficulties, pain, those types of things? Is this an effect of the central nervous system, or is the central nervous system being acted upon by some other influence? We spend a lot of time talking about treatment planning. Sometimes if somebody has had a catastrophic injury and they are in the early phases of recovery, we play an important role determining their ability to, say, return back to work or back into the community. We work very closely with allied rehab professionals and baseline assessment. So it's not also uncommon for someone to come in and say, I have a family history of a neurodegenerative condition. I have a family history of Alzheimer's disease. I'm concerned about that for myself. Or I have a family history of Parkinson's disease. Or I'm starting to show the signs of Parkinson's disease. And I know that down the line, there can be some significant cognitive change. And I want to have essentially a baseline so we can monitor how I'm doing over time. And that is a very common presentation in our clinic. We will see patients with Alzheimer's disease, various types of neurodegenerative conditions, autoimmune conditions such as multiple sclerosis, of course, movement disorders such as Parkinson's disease, and traumatic brain injuries. We also play a role in intervention monitoring. Within the university, neuropsychology has been involved in looking at outcome studies, particularly some Aricept studies that were done many years ago. And we also are involved more so now than ever before in these pre-surgical evaluations. I see a lot of patients who come to my clinic who have intractable epilepsy and are awaiting neurosurgical intervention. We play a role in talking about areas of the brain that are involved with the seizure activity, if there's any sort of contraindications or restrictions for doing surgery. The same principles apply to deep brain stimulation for movement disorder. So we will see a lot of patients who come to us by way of neurology, typically, sometimes directly from neurosurgery, but more times than not, the referral is from neurology. And this is an individual who is more or has significant concerns with their physical functioning as a result of Parkinson's disease. And part of the pre-surgical workup is to do an examination of cognitive functioning. And I'll go back just a slide here. Some of you may have, even if you haven't undergone full neuropsych testing, you may have had a brief mental status exam from your doctor. It's typically a 30-question examination that asks about orientation, a little bit about memory, and some other aspects of functioning. Neuropsychology testing is a very similar format, but it's much broader. These mental status examinations that are sometimes done either by bedside or a brief doctor's appointment are informative, but I like to sort of refer to them as almost like a thermometer. So they can kind of indicate whether someone has a temperature, say, for example. If there's a low score, there's probably some type of concern about someone's thinking skills or their cognition, but it doesn't really tell them what is causing the temperature, what is causing the sickness. There's not enough, as we call sensitivity or specificity in these measures, which would require a more full-length examination. So I want to spend just a little bit of time here. The term dementia is used an awful lot. The term cognitive change is used an awful lot. I want to talk just a little bit about what some of these terms are in our current understanding, because you may be seeing these more so now. When we think about an individual who is experiencing some degree of measurable cognitive change, so someone's thinking skills are beyond what we would expect for aging, maybe they're a little bit more forgetful than they once were, maybe they're a little bit slower in their processing speed, but for the most part, they're still able to function day to day adequately. Now, that's not to say that they won't have some bouts of forgetfulness or some difficulties where they need a little bit of assistance, but for the most part, they're independent. And maybe it's just meaning the cognitive change is just in one particular area. So maybe forgetfulness is the problem, but language and other skills are reasonably intact. We would call that mild neurocognitive disorder. To be contrasted with, and we'll go to the next slide, major neurocognitive disorder. Now, it's worth talking about the term dementia when we're referencing the term major neurocognitive disorder. In neuropsychology, dementia isn't really a term that we use as frequently anymore. When we understand the idea of dementia, we think of an acquired change that is beyond expectation for someone's baseline ability. So this is different for you than it once was. And it's affecting you in multiple ways to the point where you require more and more assistance with doing things day to day. So it's a much more pronounced level of difficulty. It's a state of functioning. So when we think of dementia, this isn't something that can be seen on a picture. It can't be seen on neuroimaging. You can't look at a picture of a brain and say, there's shrinkage in this region or there's atrophy in this region, therefore you have dementia. Now, obviously, there is a correlation. If someone has areas of their brain that are getting smaller over time and in some characteristic manner, there's a pretty good chance that they're going to be at a state of dementia. But that picture alone doesn't say how well someone is functioning. And I like to talk about like a CT scan or an MRI as a picture of what the brain looks like. Neuropsychology is essentially evaluating what the brain is capable of doing. So dementia is a state of functioning that is significantly different than the way the individual was before, and it affects them in multiple different ways. Now, there are many different diseases that can cause dementia, and I'll talk about just a couple today as they relate to the topic of movement disorder. So the format. Sometimes people are a little taken back when they call our support staff and find out that these appointments are 4 hours long. And when I mentioned earlier that these are non-invasive, there's no poking or prodding or needles, I think, what in the world are you going to be doing with me for 4 hours? And it can be exhausting, and we can understand that. Keep in mind that the first portion of the evaluation, the first hour, maybe hour and a half, is a dialogue. It's a discussion. We want to hear from the patient and their family. We understand why the doctor wanted you to come to see us. We have their notes. We have maybe even the MRI. Maybe we have other types of images that we're looking at. We have an understanding as to why your doctor is concerned. We want to hear from you what you're concerned about, because that can help us understand what are going to be the best recommendations for you. So the first hour to an hour and a half is essentially that. It's a discussion about how things have been going for you since, say, for example, the diagnosis of Parkinson's disease, or some other sort of physical or cognitive limitation that has come up. We spend the remaining time doing our cognitive testing. Typically, that's about 2 hours, 2.5 hours. And that, even being less than 4 hours, still sounds pretty daunting. We will have patients, family members that will call and say, my loved one has an appointment scheduled with you, but there's no way they're going to be able to do 4 hours of testing. And we are not in the game of pushing people too far past their limits. Sometimes, if someone has a more advanced stage of a cognitive change like a dementia, our evaluations are much, much more abbreviated. We will restrict certain measures that we think are just going to be too exhausting, and they're probably not going to give us the information that is needed. And so we need to tailor our evaluations based on individual needs. We certainly wouldn't be expecting someone to do motor-based tasks if they have a movement disorder. That's going to be far too frustrating, and it's not going to render the kind of data that we need. So we do have to make adaptations at times. But we essentially allow for the 4-hour block. It gives us sort of the luxury to evaluate what we need to, find out the information that we need, and try to come to the best conclusions that are most effective or informative for you and your doctor. So again, we're determining the presence or onset of cognitive change. We want to identify psychiatric influences. As I mentioned earlier, I'm a licensed psychologist, board certified in neuropsychology. I don't want to lose sight of the fact that I'm a clinical psychologist first and foremost. Many of you are familiar with psychological changes that go along with movement disorders, with Parkinson's disease. We don't want to gloss over that. In the interest of time this morning, I won't be going into a lot of detail about the psychological influences or psychiatric care because we've got a presenter coming up, Dr. Sarangi, in just a little bit, who'll go into more detail. We want to talk about or identify the support system, the system in which the individual exists within. So as we all know, with any condition, be it a traumatic brain injury, be it a neurodegenerative condition like Parkinson's disease, this doesn't just affect one person necessarily. A whole system is affected. And we want to provide caregiver support if needed, and essentially some clarity as far as what is going to be most optimal for your loved one in the context of these cognitive changes that we're identifying. And then differential, I mentioned pre-surgical assessment in just a little bit. And of course, differential diagnosis. Unfortunately, one neurodegenerative condition doesn't necessarily protect you from another. Sometimes there's co-occurring conditions that can come on. Sometimes we can do an evaluation with an individual who we know has identified Parkinson's disease, but we're looking at a profile that maybe looks a little bit different than what we would expect whatever typical Parkinson's disease was going to look like. We then may raise some concern about another disease process that's going on. Maybe we have co-occurring Alzheimer's disease. Maybe some of the vascular pathology that was identified on the image, the neuroimaging, is also having some contribution and is accelerating some of the cognitive changes. And those are some of the things that we want to comment on in our evaluation. More specifically to Parkinson's disease, we know that mild cognitive changes are not necessarily uncommon, about 20 to 40%. And as the disease progresses, about 80% experience some degree of cognitive change. And we won't get into a lot of the physiology, the pathophysiology of cognitive change, just in the interest of time. But suffice to say, the areas of the brain that are involved with causing some of the changes in functioning are those areas that are responsible for causing some of the changes in thinking. And I'll give you an example. I'm sure you're all familiar with the common symptom of Parkinson's disease are slow movements, bradykinesia. There is an analogous form of that from in a cognitive perspective called bradophrenia. So the slowed processing speed. So it's not only slowed movements or slowed initiating movements, but there's also a correlation with slow processing of information. And that can affect one's ability to pay attention, to focus in on a topic, a discussion, a movie, what have you. It can cause somebody to be distracted, and it can cause a lot of fatigue. If that is something that one is experiencing, it stands to reason that if they're taking a long time processing information, they may also have difficulties with memory on top of that. It may not necessarily mean that they have the same kind of memory problems that someone who has Alzheimer's disease have. They do look a little bit different, but nevertheless, somebody will come in and say, I've got memory problems. These are the things that I'm noticing day to day. We may come to find out that maybe the issue is, or the primary difficulty is problems with paying attention, problems with processing information quickly. Maybe the information is getting in there, but it's hard to access, which is a little bit different than another condition such as Alzheimer's disease. We know that there's certain risk factors. We know that early gait dysfunction. We know that those who don't have a tremor dominant profile. We know those that have more pronounced autonomic difficulties, hallucinations early on, REM sleep disorder, or movements, active movements when somebody's sleeping, acting out their dreams. We also know that there's some genetic contribution to those that experience more pronounced cognitive effects later on in life. The consensus is that, again, we'll kind of disregard the 35 to 55% statement there, but essentially 20 to 40% overall experience some degree of cognitive change. And the final point on this slide is really sort of the characteristic. So we refer to these as subcortical changes. So the regions deep within the brain that, again, are responsible for the changes in movement are those areas that are responsible, as I said, for changes in thinking. And that looks a little bit different versus some other conditions. I had mentioned that slow processing speed, but there may also be difficulties with problem solving and being in a new situation and troubleshooting, thinking flexibly, figuring out what to do next, maybe sequencing your daily activities. There may be difficulties with initiation. Maybe someone really wants to get going, wants to do something, but has a hard time initiating that task. Visual spatial perception. This is a little bit difficult to describe, but is essentially a problem early on that may be related to difficulties with judging distances or depth perception. And again, this also sort of relates to the areas of the brain that are affected. We see this most commonly with driving. Maybe someone has difficulty with gauging where their car is in relation to a stop sign or a curb or something along those lines. That doesn't have anything to do necessarily with vision per se. It's how you're processing the information visually, which is subtly different. There may be some difficulties with generating words quickly and fluently. There may be difficulties with thinking flexibly, as I mentioned earlier. And these are just some of the areas. Without going into too much detail, you may be familiar with the frontal regions of the brain being affected, the midbrain being affected, the parietal regions of the brain. And these are just for just to be complete in my description here, I wanted to identify some of the basic neural bases for these cognitive changes. We know that dopamine plays a very critical role in changes in movement, but we also know that there's other neurotransmitters that are affected by Parkinson's disease, such as acetylcholine, such as serotonin, norepinephrine, and so on. And those changes in neurochemistry also affect psychological functioning and cognitive functioning as well. I like to use this bookshelf analogy to kind of distinguish the type of memory difficulties that are more typical in Parkinson's-based diseases versus the more classic neurodegenerative condition that involves memory, which is Alzheimer's disease. And I like to use this to explain, by my observation, what some of the cognitive changes are like to patients and families. And when we think about memory, most people will say they have memory problems. If it's a language problem, they'll say, I have difficulties with remembering the word. Or if there's a movement-based or motor-based problems, I have difficulties remembering how to do something. Most people view cognitive change in the context of memory. We think about this a lot. That often is something that we are aware of if it's slightly less than it was before. And I like to think about encoding information as kind of like writing information down on a piece of paper, putting it in a book, and putting the book on the bookshelf. And then when you need that information, you go to where the book is on the shelf, pull it out, open the page, and there's that information. That's essentially what happens. It's a very simplistic way of thinking about cognitive processes, but that's essentially what is playing out when someone is learning new information and then retrieving it. In Parkinson's disease or other movement disorders, there may be a delay or maybe an inefficiency with getting all the information correct. The information is getting on the page. When the book is stored, there may be some difficulty with remembering where the book was on the shelf. But if someone says, "Oh, but it's on the third level next to the red book," oh, okay, well, there's a cue, and that information starts to come up. In other words, somebody may say, "Well, don't you remember we talked about this?" And that triggers that memory. And that is typically what we see with some of these Parkinsonian type of presentations in comparison to, as I mentioned, Alzheimer's disease. In Alzheimer's disease, the memory problem relates to difficulties with getting the information down in the first place. It may be more of a blank page, and putting the bookshelf and not being able to remember where that book is, even if you're giving me a cue. So there's a complete difficulty with getting the information in and accessing it, which is subtly different than those kinds of memory changes that we see with movement-based disorders. Now, that still translates to memory problems day to day, regardless of what areas of the brain are affected, regardless of what analogy you want to use. The individual is still experiencing problems with memory. So what is really the benefit of kind of understanding these sort of metaphors or concepts of what the differences are? Well, that does speak a lot to treatment, rehabilitation, and intervention that I'll get to in just a little bit here. When I mentioned earlier, we're talking about dementia in its old terminology, although this is still an acceptable term. Don't get me wrong, it's not something that is completely outdated, but we think of major neurocognitive disorder. This is a little more prevalent, so this level of difficulty that involves multiple areas of thinking that is significantly limiting someone's life, it tends to be more common later on in the course. It tends to correlate with age. There's other risk factors, education. Reserve capacity essentially means how much wiring there is in the brain to begin with. And so we kind of use the comparison of if there's a lot of savings in the bank, so to speak, a withdrawal isn't felt so much. It doesn't hurt as much, right? We can establish new connections in our brain by keeping our brain stimulated. It's not curative. It doesn't necessarily mean that it compensates for those cells that are dying off or being affected, but it allows for a reserve capacity that can maybe stave off some of that progression just a little bit. Now, this can be keeping oneself or your mind occupied with reading, music, the arts, what have you, but we also know that physical activity, exercise, can help cognitive reserve as well. Okay, so biomarkers for cognitive change. So as I mentioned earlier, and I'm just about done here, as I mentioned earlier, there's a lot of pieces to the puzzle that we're looking at when we do these evaluations. Again, sometimes I'll have individuals come to my clinic where their presenting condition may be having an effect on their cognition, but I also think that maybe there's something else going on as well. As we stand here today, much of these diagnoses are clinical diagnoses, in that there's not a clear blood test that says, aha, you've got this condition. These diagnoses or conclusions are based on clinical examination, looking at blood values, look at neuroimaging, looking at what else may be accounting for why the individual is experiencing difficulties. CSF biomarkers can be helpful for looking at possible Alzheimer's disease. MRI findings are informative because it can show areas of atrophy, of structural change. Maybe there are some reversible processes like hydrocephalus that need to be accounted for. And then, of course, DAT scans to look at the diagnosis of Parkinson's disease. I just sort of have an illustration here to distinguish what we refer to as cortical signs. So cortical dementias are Alzheimer's disease and to an extent Lewy body disease, versus these subcortical changes known as movement disorders. Language looks a little bit different in each. Speech may be normal in a cortical dementia, but dysarthric or slurred in someone who has more of a movement-based disorder. Memory, I sort of already discussed. Amnesia describes memory, but it's more specific to complete inability to encode and hold on to information versus being forgetful. In other words, the information's there, we just need to bring it up. And I talked about some of the other aspects as well. We have a presenter in just a little bit who's going to talk about this Parkinson's dementia versus DLBD. Essentially, what we're looking at is a timeline. And so if somebody presents in my clinic and they've had movement symptoms and they've had significant cognitive impairment within the past year, and so all of these have sort of come together and converged early rather than later, and there's some other supportive features such as hallucinations, pronounced REM sleep disorder, I start to think about diffuse Lewy body disease in comparison to Parkinson's cognitive change, or Parkinson's dementia. Again, we're going to have a presenter later on who's going to go into that into some detail. So what this all boils down to is this is data, this meaning the neuropsych testing data, is hopefully informative for an interdisciplinary team. It takes more than one provider to manage most medical conditions, or at least it should, ideally. These data that we generate, these cognitive findings that we conclude from our testing, may speak to the need for pharmaceutical intervention, neuropharmacy. We may need to address mood, either from a pharmacological perspective or from a behavioral perspective. Cognitive rehabilitation has found to be beneficial to a degree. Sometimes we'll make recommendations or referrals for occupational therapists, for speech therapists to help with communication, with memory, problem solving, what have you, and overall lifestyle management. Sometimes we're making recommendations about one's living environment. My bias is to encourage individuals to do as much as they can, or as much as what they're capable for, as long as they can. Now, sometimes the progression of the disease gets to the point where the individual is less capable than they were for, say, making important decisions in their life. Maybe our data suggests that they would benefit from having some additional support by way of having a trusted family member be appointed a durable power of attorney, or sometimes even guardian, to help oversee financial matters, health-related decisions. Sometimes we're concerned about driving. Sometimes our data suggests, it would probably be to your best interest and those around you that you don't drive. And that's a tough sell for people. And I know that is not something that I would want to hear. And so I have to appreciate the way that I'm going to communicate that to those that I serve. Again, I don't want to forget the fact that I'm a psychologist first and foremost. I can't just come and say, well, you shouldn't be driving anymore, and that's what our data says, and you're just going to have to deal with it. That would be a terrible way of going about it. I wouldn't want anybody to say it to me that way. I would want a little bit more of an exploration of alternatives. So I have to keep that hat on as well, that psychology hat, the general clinical psychology perspective as well. That's a lot of information in a relatively short period of time. All right, with that, I'll pass the torch. Thanks.